Solomon?
No, I think it's going to go right now. Good evening, New York City, and thank you so much for tuning in today, a day of National Black HIV awareness, a day to remember the history of HIV and AIDS and its disproportionate impact on our Black community, and think about the ways in which we can continue to fight HIV and AIDS. It is not erased, it has not gone away, and there are still many individuals who live in this on this planet, in this city, without access to certain things like testing and treatment. And it's for many different reasons why that occurs. And it's for this reason we have gathered an amazing panel of experts in their field who are here giving of their time so graciously to be able to inform our city about the best ways to approach the difficulties for those who have barriers to accessing treatment and testing around HIV and AIDS. And I am glad to have you all on this beautiful, lovely stream this evening. My name is Solomon Acevedo. I use he, him pronouns, and I'm the Deputy Public Advocate for Justice, Health, Equity, and Safety. I'm going to introduce my co moderator today, the amazing Kim Watson Benjamin.
Good evening, greetings and salutations, and all the blessings out there to everyone. Thank you so much. We're going to have a wonderful panel this evening. My name is Kim Watson Benjamin. I am the LGBT and Health Coordinator here at the Public Advocate's Office of New York City. And this evening, I would like to introduce my wonderful panel, which I'm looking forward to amazing conversation and messages and upliftment as we process this whole discussion. And with no further ado, I would like to go ahead and introduce Kadeem, please.
Hi, everyone. Good evening. My name is Kadeem Robinson. I use they, them pronouns, and I am the Director of Legislation and Communications for Councilmember Pierina Sanchez, and I am very much excited to be with you all. I'll kick it to Nikita. Did I get that right? Awesome.
Hi, everyone. My name is Nikita McPherson. I'm a physician assistant. I work in internal medicine. I have a specialty in HIV and Hep C, and I'm happy to be here with you guys today.
And we can pass it on to Reginald.
Good evening, everyone. My name is Reginald Thomas Brown. My pronouns are they and them. I am board chair of Vocal New York. I'm on the HIV Planning Council. I'm also on the Hostage Advisory Board. I'll kick it off to Nikita. Nikita.
Oh, Nikita went already. Let's go with Mimi.
Mimi.
Thank you.
Hi, everybody. My name is Mimi Shelton. I am representing myself tonight on my own behalf, but in terms of the work that I do, I am currently working as the NHBS Trans Project Coordinator, which is a research project under the Department of Health and Mental Hygiene. In terms of the work I have done that is related to community, I was recently the Director of Trans Initiatives at Destination Tomorrow, which is the LGBT Center in the Bronx, where I was a grant manager for a national grant around HIV, social determinant work, and other HIV community-based efforts. And in addition to that, before I was an educator for about 4.5 years, a middle school English teacher, and I have been doing a long-standing activist organizer when it comes to race, gender, sexuality, equity, and a variety of life, education, community work, and what have you. So I'm excited to be here and to join my colleagues and co-conspirators, and I'm going to pass it off to Dr. Milano.
Thank you so much, Mimi. And let's go with Dr. Milano.
Hi, good afternoon, everyone. Thank you very much for the invitation. It's a pleasure and an honor to be here with such a wonderful company, people that I know for many years. I work called Community Healthcare Network. I've been with them for 33 years. And this day is very special for me because we started 33 years ago. We started the first program in a country that was testing women for HIV. Back in '86, and Reginald mentioned that we were only doing HIV for gay men, and we forgot about women. And that's significant because today we still are forgetting women, transgender women, and cisgender women in the provision of PrEP. And so sometimes we learn, but sometimes we stay in the same place. And I think that for me has been a privilege to work with Ms. Watson. The transgender community has been an ally for 18 years when saying the word transgender was not fashionable. And so far now, I'm very happy that God has blessed me to do this work. And now I continue to do it at Community Healthcare Network. And we have 5 clinics when we have services for people with trans experience. I believe that together we can make a difference regardless of the obstacles that we find ahead. And I'm going to pass it on to Lee.
All right. Hello, everyone. Can you hear me?
Yes.
Okay. So I apologize for I had a struggle getting on, honey. Didn't realize I didn't have a Google on my Mac, so I apologize for popping in so late. But I'm Lee Soldier Simmons. I'm the executive director of the NYC Center for Black Pride. I've been running Black Pride here in New York for the last 15 years, but this year we're celebrating our 25th anniversary. So I'm excited about that. I know a lot of you here have partnered and talked to you guys on many occasions and stuff. So outside of that, I do a lot of other community things. I also do entertainment work, fashion shows, all type of things. Connecting community and stuff is the my biggest, I guess, claim to fame is always finding ways to connect community to services, connect community to people, resources. So I'm honored to be a part of this conversation.
Awesome. Thank you so much. Truly, 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 I'm grateful to have all of you here. Like I said, you're in the presence of experts, and we're here because it's not an accident about what happens to our Black community when it comes to racial inequity and disparities when it comes to health. And in 2019, an estimated 1.2 million people had HIV in this country. Of those, 480,000 people were Black. So we're here to talk about the history of HIV and AIDS, how it disproportionately affects our Black community. And we're going to start it off by passing it to Kadeem Robinson because today, this morning, we did a little event and Kadeem speak to that and let's go more about how we can expand the work that we've been doing. So Kadeem.
Yeah, thank you, Solomon. And first, let me say that I am very grateful and honored to be amongst folks who've been doing this work for as long as I've met them and way long before that. So I feel very honored to be in the presence of folks who've been advocating and pushing towards equity in terms of how the city, the society responds to Black folks as it relates to HIV treatment, care, and prevention. So thank you, and I'm honored. As Solomon mentioned, today we kicked off national. I'm a little bit nervous. National HIV and Awareness Day today by having a press conference at the City Hall steps. And this conference was, of course, to acknowledge and observe today. As we know, it was from 1999 that the first ever National Black HIV/AIDS Awareness Day started. Pretty much as a grassroots effort to bring attention and raise awareness to the various disparities and disproportionate impacts that HIV have and continues to have on the Black community. And 24 years later, here we are acknowledging and recognizing that there's still so much more left to be done. And we, of course, also rallied in favor of introduction 895, which is a new bill that was recently introduced at the New York City Council alongside Councilmember Pierina Sanchez and the public advocate Jamani Williams, as well as a whole host of other council members who equally value the importance of centering Black lives in health equity. And so this bill that we rallied in favor of would essentially expand express testing clinics. And so, as we all know, or some of us may know, back in 2019, the Department of Health and Mental Hygiene created this amazing facility called the Quickie Labs. And I think the first one was in Chelsea. And the Quickie Labs are essentially would have a laboratory under the facility where folks would be able to receive testing for various things: HIV, gonorrhea, syphilis, chlamydia, and receive the results within the first day or within a few hours of receiving that. And so later on, the city expanded to Fort Greene, Brooklyn. And so now we have two sites. But at the onset of the pandemic, unfortunately, the same facilities and machines that were used for these testing actually had to be switched around to use for COVID testing. Now we're back. Now that just very recently or some months ago, the Department of Health and Mental Hygiene announced that these machines will be up and running again for express testing for STIs and HIV. But the issue is there are only two. One in Chelsea, as I mentioned, and another in Fort Greene, Fort Greene, Brooklyn. And the issue is that this doesn't necessarily address or is proportionate to the rates of transmission in communities of color, in Black communities throughout the city of New York. And so Introduction 895 aims to expand these clinics, expand these Quickie Labs, expand these express clinics to different communities where more folks can have access to rapid STI testing and treatment so that we can work to reduce the rates by which many populations are disproportionately contracting STIs and more. Particularly, a lot of the folks that we're seeing is young adolescent girls, ages 15 to 19, of course, queer, bisexual men, and of course, Black women and Latinx women. We're seeing like very disproportionate rates on. So this bill is really just a first step towards the direction of ensuring that we can have health equity. And the way in which it does so is, one, ensures that there are more Quickie Labs in the hardest hit communities, and two, ensures that there are educational campaigns that the Department of Health and Mental Hygiene conducts within those same communities where the disproportionate rates of all the syphilis, the gonorrhea, chlamydia, and more are in our communities. So we are very happy to have worked with a coalition of folks today, ranging from African Services Committee to the Caribbean Equality Project to way more organizations that I can remember at the moment. But we really worked together and rallied together to ensure that we're bringing attention to this bill a little bit more, just to ensure that it can eventually lead to its passage. So thank you. And if anybody has any questions on how they can support the bill, please feel free to reach out to me. Solomon has my contact.
Thank you so much, Kadeem. And it was truly a powerful moment this morning, and beautiful to see so many people really come together around an issue that, because of COVID-19, as you mentioned, has been impacted in terms of its attention. And so I guess if we want to contextualize that in a good, we can kick it to our first question, which is, how did the HIV/AIDS epidemic uniquely affect the Black community historically? And how did COVID-19 impact that development and process, for better or worse? And anyone can go popcorn style.
Okay, I'll take this one in the sense that, unfortunately, or traditionally, the black community and the brown community has been surrounding the table, but not really sitting at the table. And that to me is a problem that even exists today because when we have whatever rise in the numbers, COVID, STIs, the last part of the community that we will focus or that will bring to discuss the issues are the black community. And it's very interesting because even with the MPX, and let's not forget that one, when I went to have my, after trying several times when I went to have my vaccine, it was in Harlem, and I saw 7 people, none of them that were of that skin. So that made me think that here we are 33 years later since I started working with HIV, and we were focusing on the people of color back then, but then still today we bring the community at the end. It's like I remember times that we said we need our place at the table. Now, guess what? We have to make our own table, and we need to decide who we want to invite, who want to sit with us at the table, because obviously we are not part of the first play or the first server at the table. I think that that's something for us to think about it. And now that the numbers are coming up again, it's our responsibility to ensure that our brothers and sisters are getting all the information, knowledge, and whereabouts of where we can go so we can protect ourselves.
I'd like to add to what the Dr. Milano said. Also, HIV was marketed. The narrative was that it was uh, white men. That was the narrative for the longest time. So if you don't see yourself in the advertising, if you don't see yourself as part of the narrative, you think, well, that's not me, that's them, that doesn't happen to me. I mean, this is the way that this country, the country has a narrative. The narrative is what drives policy. The narrative is what drives the way that people think. So many people, I think, for the longest time thought that was not available for them. Also, there is a historic mistrust within the black community, rightly so, of the medical profession. I mean, the Tuskegee experiment went on from the 30s into the 72. I mean, this is like recent history of allowing black men who had syphilis to go to stage 4 syphilis just so they could see what the results would be. There were also experiments on black women without anesthesia. So there is there's justified mistrust of the medical profession. I guess my job as a queer black person is to lead by example and say that, you know what, I hear what you're saying. I don't, and I guess I understand your reluctance. But on the other hand, there are things that are there that help. I was diagnosed HIV positive in 1986 and told that I had 2 years to live. And at that time, HIV positive diagnosis was a death sentence. I've been undetectable since 2003. I have had no AIDS-related illnesses in the 37 plus years that I've been HIV positive. Why? I go to my doctor. I watch what I do. I take my medication. So people, look at me. It's okay to go. I mean, I hope you can get over. Like I said, I'm sorry. All I can say is I can lead by example. I can't really tell people what to do. I can just say, I've done it, worked for me, and I'm in good health. I'm 71 years old, and I'm living my best life.
It's so great to hear you speak, Freddie. Excuse me, not Freddie. I'm seeing names on the page and not making things click. Reginald, it's so beautiful to hear you speak, and I thank you so much. I actually want to follow up because I agree with both your point on the medical mistrust in the Black community and how that historically has linked to disparities when it comes to care as well as community accessing treatment as well when around HIV, as well as your point about the lack of representation in HIV care, particularly in who is seen as an HIV patient or who is seen as having HIV impact them in their communities. I do know that the Tuskegee experiment was exposed in the 70s, which in addition to other political projects happening at the time, I know led to a lot of government mistrust on a national level among many communities, but it was particularly tough on Black communities. One, because we were the subjects, and of course, Black individuals were the subjects we were of that research, and of course, with the legacy of Black men and with the legacy of Black women, both not only being tested and experimented on, but really creating the or aiding and creating the legacy of gynecology, being experimented on by the I don't his name evades me, but it's not important. Whoever created gynecology, that individual utilized without anesthesia slaves and also Black women generally. So that's one thing. But then also we have to think about I think a lot of people who are not as familiar with HIV think that the only avenue to getting it is being queer or being gay or being trans or what have you. But I think a lot of that, again, we have to, and I can talk later, detach stigma and colloquial beliefs from what is actually real and statistical. And if we're thinking about a population of interest when it comes to HIV care, treatment, intervention, prevention, people with drugs, people who inject drugs, and we know that the crack epidemic tore apart the Black community in the 80s, and that is not only just crack. There are so many other ways in which. Unfortunately, because Black individuals and Black communities are often overrepresented in working class, poor, impoverished, and also uh, mentally ill and also other populations, we happen to be a byproduct of that. And I think that the 80s added to and added to the HIV uptick within Black communities. But what led to a lack of seeking access had to do with the legacy that Reginald was just mentioning. So I wanted to bring that back up. And then I would also add that lack of representation was very important. I think that we still see this today where whiteness becomes the default across identity categories for who should be the representative. I experience this now as a trans woman with every time I Google trans or see something new coming out about trans people, it's always a white person, white mask person, white trans femme, white non-binary person. There's a legacy of erasure of BIPOC folks. And so I think that wrapping it back around to Reginald's point, of course, I'm not as familiar with the campaigning throughout history, but what I am familiar with is that when AIDS and HIV treatments were beginning to be dispersed in the 90s, they were not accessible, and intentionally so, to Black gay men, right? And that had all to do with race. And racial implications, and those AZT drugs and those other medications became readily available to gay white male patients. And I think we see those same disparities around the MPV vaccine that just happened last year, and the lack of inoculation rates among Black populations who were some of the individuals who were the most impacted by mpox. So lack of representation is a huge thing, and lack of representation, and I know it may sound like, oh well, why do you want to be represented as being the face of HIV? That's not what I'm saying. I'm saying when it looks like this epidemic is not impacting your community, and it is, right, because it is not a virus is not confined solely to a particular race or a particular gender identity, because those are social categories, right? But if we don't see that, like, this is also an issue impacting us based on advertisements and the faces of the people in those advertisements, based on medication, right? Or if we see oversaturation of us, it can send a particular message. And oftentimes the lack of people sends a message, just as Reginald said, that this doesn't matter, that this doesn't pertain to me. And compound or compile that on top of the fact that there's also this medical mistrust within the Black community, while we're simultaneously having our own rates of infection and illness be most impacted because of racial disparities, and we're not accessing and seeing ourselves in care and treatment. I think that those factors all play a role in that history.
And I would like to add to this conversation, if I may. I definitely want to say that, and to kind of piggyback on what the three of us said, especially Freddie. I think that in the beginning, representation when HIV and AIDS in the 80s first came to the forefront of everyone being aware of how it was impacting the community. People of color, Black people, we weren't at the table. So we had to first fight to have a voice, to be at the table, to be a part of the conversation. And I think that has not necessarily, yes, we've been added now into the conversation, but it seems that as things have been progressing around the release of medications, the release of PrEP, and we still see it today, as you talked about monkeypox and all these different things, it seems that we're still slow to being a part of the direct conversation. It seems like we always are an after the fact. So I think that that's also something important to talk about. We can also talk about how stigma really impacted us during the 80s and the early 90s when HIV pandemic was growing and so many people were dying, and as Reginald said, that it was considered to be a death sentence. So everyone was scared and didn't really understand it, didn't really understand how many friends of mine are gone from that period, and some of it may have been overted, or they just didn't want to go to a space to get help. They didn't want to go and find out about the medications. It was kind of like you were damned if you did and you were damned if you didn't. So, stigma was just as dangerous and did just as much damage within the community in that period, keeping people from getting help and seeking help, than just those that were already diagnosed and felt like they had the death sentence. You understand? So I think that we have to historically talk about that as a community. Also, I'm going to speak from my last 15 to 20 years of doing community stuff. One of the things that's always a conversation with community folk is about prevention. So for some reason, culturally, we tend to seek a doctor when something is wrong. We go to the doctor when we have symptoms that something is wrong. And we kind of are trying to talk to people about changing that narrative. Go get tested, find out your status, be ahead of a situation. Prevention is just as important. And so changing people who culturally, a lot of us, unfortunately, necessarily don't have insurance and all the things, so prevention, which should be at the top of their list, is not always at the top of their list. We have been culturally taught to respond to a situation instead of trying to avoid or prevent the situation. So teaching people about condoms and all these things, and now educating people about PrEP, which I will also say felt like we were behind the curve in that. I remember going out to gay pride parades and seeing the white community, with t-shirts on saying they were PrEP whores, and everybody was looking at each other going, what the hell is that? So it felt like we were finding out about PrEP after the fact. Some people were already out there and finding ways to get on it or get access to it before the Black community was able, and the Latino community was able to respond to it in the same way. And I'm going to add to, like I said, just reading, talking about monkeypox, going to the health department in Harlem and seeing the line, and I was one of 3 people of color on that line, and that's crazy to me, that I had to sit down with people in the city and the state health department saying, what could I do during Black Pride? How can I change that narrative and get more access to our community, or make it more accessible for people in my community to get the shot, to get tested, to do what we can. And I remember talking to them about, these are the places we can find them. So Not to say, you're going to wait for people to walk in or try to make these appointments, because that wasn't working. So here, go to nightlife. These bars on these days, this is where they're going to be at in the city. These are the locations. This is what's happening around the Latino community. This is happening around the Black gay males. They're going to be here and there. And I was happy to see, especially during Black Pride, that the health department responded by sending people to actually be outside those venues and those spaces and sign up people to get them those shots and things. But I guess my point to that is, wow, why would we have to go through so many extra steps to equally meet healthcare needs for our community? We always have to take or do more. Doesn't seem like healthcare is evenly distributed or accessible to everyone equally. It's like we have to always do the extra. So with that being said, there is, it adds to the mistrust in our community of health workers, of the health department, of the system in general. So even when they do release stuff and you're hearing about it, you don't trust what you're hearing. You don't trust the information. You want to know more about it. It bothered me also to have a conversation, and I am not trans, to have trans women who sit with me on my board and go, why aren't trans women at the table? Why aren't they part of this conversation? Why aren't we talking about what happens to them while they're on hormones and they're taking these medications? Oh, wait a minute. Was that not part of your research? Was that not part of the, why aren't we asking those questions? So here again, we're not equally at the table. We're not equally being asked the questions. And so therefore, when these things happen, and then when the burden of these pandemics and epidemics rest on us, there's reasons why you didn't include us. We weren't part of the conversation. You wasn't worried about us at that point. You're worried about us now. And so I know that this kind of a little bit off of it, but it continues. Now we're talking about COVID. And so COVID hit, and that became the priority for everything, right? And I remember, and I just came out of the hospital because I got COVID early. I had gotten COVID in March, and it hit me bad. I was in the hospital for 6 weeks. And I remember coming out and being asked to be on a panel to talk about how it was impacting me. And New York was in lockdown, and I got on this panel discussion, and it amazed me how the conversation coming from people in the health department was saying, like, as if we're not having sex anymore because it's COVID and we're in lockdown. I was like, are you kidding me? You think that gay people stop having sex? What, you kidding me? As if you don't know there's apps and everything else going on. Child, they probably having more sex. I mean, they got to figure out something to do with their time. They're gonna get it in. And so, yeah, okay, we all are worried about catching COVID. So we stopped worrying about what was going on with HIV and other things. I want to add that not just COVID, we have a Tina pandemic that is hitting and destroying our community. And when these folks are on that particular drug, they're not worried about a condom. They're not worried about protecting themselves. And so their immune systems, and sadly to say, we are losing so many people because of drug addiction. Homelessness is an issue. So you can't be looking at people wondering if they're wearing a condom or if they're worried about protecting themselves and COVID and everything else, because they ain't got a home. And so we're not really addressing even people who are getting meds and stuff, having homelessness compliance to staying on their meds. How do they comply when they ain't got a home? They're worried about where they're going to sleep and eat. There's just so many other pieces to the conversation. There's so many intersectionalities to the conversation. And I feel like because of all of those conditions, we're left out of the conversation. Like, we'll deal with them after. Let's deal with this first, and then we'll get to that. And while you're waiting to get to that, it's still festering and is growing into a bigger problem all over again. I think I'm worried about, we've spent so much money. We found so much money to work to deal with COVID and monkeypox, and we've put HIV on the side because there's new medications now. So they kind of feel like, people aren't dying in the numbers that they were before. So it's been kind of sidelined, that I just feel like, no, you're really setting it up for a second a second issue to come. You're really setting it up for a rise in the conversations again, instead of, no, keep this in the conversation. Yes, maybe we need to focus on those things. And I'm not suggesting that we don't. However, not having those conversations, not dealing with, what's happening in drug abuse and homelessness, and people can't even afford to buy a loaf of bread and eggs right now. Food and stuff is so expensive. We got to keep these things in conversation, because if we don't, we've seen history-wise, it's going to cause the problem to arise all over again. And that's my 2 cents. Maybe it was more like a nickel, but
or maybe $5. Thank you so much, Lee, for impacting on it. This is like a beautiful portion of the conversation, because we get to address historical trauma and the ways that it intersects with so many other aspects that I think all of the panelists has mentioned in some way or another, in terms of access to testing, in terms of the impact of stigma on individuals seeking access, in terms of also, the other supportive structures that need to be in place for an individual to sustain treatment over a long period of time, to be able to live a healthy, strong life, as Reginald is exemplifying. I just wanted to turn it to Nikita McPherson to talk about the kind of ways that people experience barriers when accessing healthcare, and to see if you have any ideas on what it is that can help people get over the barriers to that access.
Okay, so in regards to barriers of access in healthcare, one of the barriers I was talking about prior was when it comes to us as colleagues or us as treaters, just being open and just really not having any stigma, just testing people for HIV. I think it was Lee who said before, when you're talking about prevention and asking people to go and get treated, or go to see your doctor, don't wait till symptoms come up. So one of the things that I do in my practice, but I try to educate my colleagues to do in practice, is let's just do an HIV test. Let's ask them if they need to be HIV tested, not just HIV, STDs as well. Because during the pandemic, I was treating it a lot, where we were seeing a lot of STDs, chlamydia, gonorrhea, you name it, we were seeing it. So we had to be actively treating during the pandemic. So I do agree with Lee again when he's saying that everybody's having sex, and it was because we were so locked down. Yeah, you're gonna find means and ways to do it. So it was a rise when it comes to STDs. Barriers that we do have as well is, I think, also is education when it comes into healthcare. Some people shy away because they don't know when it comes to the patients, but also us as providers and treaters, sometimes we shy away without, we don't want to ask that question. We don't want to ask if you're having sex. We don't want to ask if, you're using drugs and stuff like that, unless you're into that discipline. So these are ways that we could be helping the community by, if we know these things, we can also have things, because in my clinic, we do have some outlets where we have case managers that help them to get into different programs if they're on drugs and they're willing to stop. We have medications like Suboxone and stuff to help them, or people that are in methadone programs to help them, so that these barriers will stop, in terms of them not for them to keep going on in terms of the healthcare in the community. So my 2 cents on it is that barriers, we do need help in like mental health as well. Mental health is something that is very ongoing, and it was on a high rise during COVID. And I saw it especially in the community I work in. And it is hard because as providers, there's not a lot of people. Us as primary care providers, we are treating to help with the onset, but there's some things that it needs a psychologist and psychiatrist. So we are looking into other avenues, or trying to find other avenues to help that, so that there won't be a barrier in people, one, being compliant to their medication, and also to keep them non-detectable and keep them living a healthy and quality life.
Can I also add something also to that? Because one of the things I guess I neglected to talk about, running Black Pride not only is about for me just connecting community, it also has been very educational for me because Pride is for all segments of the community, right? Trying to find ways to create safe spaces and events and create conversation for community. And I've always wanted my community to represent, it's not about a Black gay man trying to dictate what a trans event should look like or a lesbian event should look like. It's always about us coming to the table and having these conversations. And they have been very educational for me. And I'm going to speak on something about this because I had learned a lot around cisgender women. First, I'm going to talk about around HIV and AIDS. I remember working with a group at the LGBT Center, had asked me to come in and to help them to put together an event called Many Women, Many Voices. And this was an outreach they were trying to do to educate cisgender women and lesbian women around HIV and AIDS. And I remember dear friend of mine working from Gilead came and she was making a speech and she stood up in the front. It must have been about 200, 300 women in that room. And she asked the women, how many of you think that you are vulnerable to getting HIV? And to raise their hand. And I tell you, not a single woman raised their hand. For whatever reason in their mind, they didn't raise their hand. She made her presentation. At the end of it, an hour later, at the end of her presentation, then she asked the women in the room, now how many of you think that you possibly could be exposed to it? And every single woman in there raised their hand. That said to me, wow, how the way that we are, talking and having these conversations, we're not having these conversations with women, meeting women where they're at, making them understand that it's not just this gay males thing. Women are getting it also. I also spoke at a Black women's health event, and it was predominantly straight women, cisgender women, who were explaining that they were having a hard time with guys that they date, and even some of them with their husbands that they suspected that was cheating and having multiple partners, how to navigate asking them to put on a condom and feeling like they couldn't do it. And they were at risk of whatever their partners brought to them. And that was so educational to me. It was saying to me, wow, here goes another part of the population that we're not really discussing how to empower them, have these conversations because we're focused on males, on gay males. Then some trans women who were sitting on my committee and said, let me tell you something. What irritates them was saying how the conversation was always about clumping trans women in a conversation with men. You come into a space and you're seeking help and they're talking to you about gay males. No, I'm a trans woman. Talk to me about how this is going to impact me with what's going on in my body and my life. And if you start the conversation off talking to them as you would a conversation with gay males, it's kind of insulting to them. And the research was mostly around males. Again, it still said to me, wow, we still got so much work to do about learning how to be inclusive in conversations when it comes to health, about how to do that.
I would even add, like you've actually got me to come off mic because you bring up a lot of the points. That's why I brought up the point about the crack epidemic earlier, because since the 80s, the rates of infection among Black women have been tracked and they're egregious and they've been on record. And the rate of transmission between mother and child has been egregious. And because so much, and in addition to that, the rates and how they impact such a vulnerable and not small, but percentage-wise of how much of us are out there, we get impacted at egregious rates, particularly Black trans women who are in rates of all trans women studied who get tested, we're 50% likely to have HIV and to have that rate. And we are nationally, I believe it's 49% now of the population of Black trans women have HIV, to like 20% of white trans counterparts, to like 30 some percent of Latinx. And for so long, we had actually been tracked as MSMs in that research. So much of the research, unfortunately, around HIV surveillance has captured transgender people incorrectly. So there's so many ways in which to add to where the question of talking about these barriers comes from. I think that so many people don't recognize that the barrier to accessing care doesn't begin in the hospital or in the doctor's office or in a conversation with your friend or in community. The barrier of accessing care begins with those social determinants of the social determinants that would lead to a higher HIV or STI rate, right? Some of those include, can you afford transportation to get to and from the doctor's office? Do you live in an area where there are accessible, treatment facilities and clinics, or do you have to drive or take transportation, which also is a cause, to get to those facilities? Do you live in a rural area versus do you live in an urban area? If you live in an urban area, are you living in a Section 8 or in an impoverished area, or are you living in not one of those areas, right? I think that because people get so fixed on identity politics around trying to put a face to who and what and how viruses and bodies are impacted, we've gotten our own selves as a culture, as a community, as a world, trapped in our own logic, in our own cycles of knowledge, to where we can't even decipher between, by not us on this panel or we or in anyways, but just between what virus and biology is, and if it does happen to come up in a particular category of identity subjects, then how to address that without making it associate the virus or the disease or the body illness itself with the person. We still don't know how to do that anymore because it's been built into the fabric of our country and into the fabric of science itself. And so the issues I think that arise is that we have to look at what are all of the social implications that would lead to that, right? Like I just added, where you're living, transportation, stigma. Like, do you think that you could be impacted? Which I love that you brought that up, Lee, about, being in that women's workshop and people raising their hands, because it's like, how many women, how many trans women, how many people still believe that it's a gay virus, that it's just a gay disease? So there's still so many people who threaten, even in online bullying, they're like, you gonna get AIDS, to trans women, trans people, and queer people, and they still associate it with being a queer virus, even though there's so much research to show that it is not just a queer virus. And then we leave out so many sections of people and who can be impacted, right? Like I just mentioned, people who inject drugs, like who are also homeless, right? Which also, if you don't have a house and if you don't have a job, right? And let's say you are formerly incarcerated and you're disqualified from even accessing those things, like so many of the barriers to access begin with those social determinants, which again start well before we enter into the doctor's office. And I think that a lot of that can only be addressed through continuous challenging of cultural narratives, especially right now with a really vicious culture war that we're living in, and or in among second wave of it, I should say. And in addition to that, going back to what Leah is saying, I think it's recognizing for ourselves and educating ourselves and having conversation openly, right? Because just as Lee has said, there's so much I still don't know and I didn't know about, like, who can be impacted by HIV, what that meant. And I think being a person who has been victimized by the stigma of HIV and never been necessarily a person infected by it, I think that for so long, it stopped me from even keeping on regular track with my care and making sure I'm getting all of my regular 3 to 6 month tests and STI tests. And it was really only in 2018 when I was finally able to procure like medical coverage stably, that I was able to finally get on a regimen where I'm testing myself fully and, constantly knowing my status for the very reasons we're talking about. I think, and right now, unfortunately, a lot of younger trans and queer people across the spectrum are starting to not get tested or don't want to know their statuses, particularly because of a lot of anti-LGBTQ rhetoric that is on an uptick, and because of being associations and things that were already there. And so I actually am really worried about what it's doing as well to younger populations of individuals, particularly in the like 14 to age 30 category, 13 to 30, because we're having sex, right? And kids, youth, especially those who are the ages 13 to 18 are and beyond, are doing it as well. And they're experimenting. And because we live in a society that claims to be repressive about sex, even though it's proliferated in everything, we don't do a good job educating people on how to have sex, on how to seek these resources. So again, another social determinant is the barriers in our own education systems and how we're taught. Like, I bet each one of us was taught about sex in a vastly different way, both outside of the school and inside, mine being completely abstinence based because I'm from Virginia. So just like the vast narratives, state level, local level, and federally around sex and sex education indicates that.
But I think it's also the fact that we need to look at who is bringing the message to our communities. During COVID, HIV, COVID, MPX, uh, we didn't utilize the leaders that are there in the community, guiding the community in the way that we should have done it. And rather than to set policy from the top down, instead of coming to the community, who's engaged with what? When we set up those mega sites for vaccination in the Jacob Javits Center, how many of us can go over there
Hmm.
in a car, which is far, far away? When we go in dealing with COVID, no transportation, walking over there, waiting in those long lists. Instead of engaging the community leaders, that I found that when we were going out in COVID every weekend, the power of the faith-based community leaders is so big that why didn't we go to them? We know that we have so many outlets in the community, like the bodegas, like the laundromats. They know who's coming in and out of that community. And
Mhm.
instead of having the photo up that many were looking for,
Yes.
if we had engaged in those moments with those community leaders, that will give us also the opportunity not only to do a better job, but also to create a second, another second, is like fifth generation of educators, because the way that we learn, and Mimi mentioned that the way that we all learn about sexuality, Lee mentioned about the prevention, and we need this generation today. I think that we have to mix all the different components. Prevention is very important because with prevention, you're saving lives from the beginning. It's also financially more viable. Talking about sexuality, how many of us has gone to our own, and we are patients somewhere, and our doctor has addressed my sexuality, why do I do sexually? They don't want me to talk about it because then they have to talk about how to minimize the risk factors. In all of us, in a way, we are sex workers because our all those infections start with sex. So we have to recognize that sex is integral part of us. However, how do we present that message is changing from generation, and that's why we have to reach out to the people in the community where we have good leaders today. I have here people around 14 years of age talking beautifully about sex, about in a way that is progressive. I have seen people that talk about um, ministers and pastors that talk about prevention in a way that I say, wow, that they are allowed to say this in the church. And so those things we have to know. and go with the change. And another thing that it is important, and sometimes I disagree with the social determinants of health, because when Reginald probably remember that money was that poverty was there from the very beginning. Every number of years we find fancy words that we say we're going to work on that. We're going to do that. But
Mm.
after a while, after the initial um, opportunistic propaganda, we forget that we have been having the poverty since ages. When we
Yeah.
were preventing asthma in the children, we give the medication to the child, but we don't remember that that child has a broken window in the room that is giving him, making sick again and again and again, sensing with HIV and STIs. We also have to think about that for many, the sex business is survival transactional sex. This is the only way that they can survive. And even with COVID, our sister was on the streets. They were looking for the clients. They were because they need to survive. How do we approach that? And I put a lot of responsibility in the medical community that we have not done a proper way of educating or talking about sexuality. And also, part of us that we need to be more aggressive on demanding that we are given a seat at the table. Because if not, you know what? I'll say it again and again. We have to get our own table and invite other people to sit with us when we are planning about community health, because community health is what we are about it.
Wow. Freddie, can I say thank you for bringing that up? Because stigma is important. And a lot of what you just said, we need to destigmatize sex workers. Because let me tell you something. When trans women say to me, child, they got a problem going to the doctors and navigating, getting help around those things and having a conversation or automatically being assumed that they have to be a sex worker because they're a woman of trans experience, that's a whole nother lengthy conversation. Also, it's the same thing actually, for cisgenders. For them to go and talk to their doctors about getting on PrEP and feeling ashamed that they have to explain as if it doesn't mean that you're promiscuous and you're doing all kind of sex because you're asking for PrEP. So a lot of them is stigma around like, are you asking for this because, you're out there doing all types of things? Well, sexuality, sex is fluid. And it really shouldn't matter to me when a patient or a person is coming to you for help that, yes, we do need to have those conversations to kind of understand that when I'm speaking to someone, that I'm connecting them to the right resources, not because I'm judging them about what they're doing, because, hey, we're all having sex too, but because I want to make sure that I'm connecting them to the people that can help them overall. You understand? It's more sometimes there are other factors and things that are happening to them or they could be exposed to. Now, I'm going to say in the last 6 months, you know what? It's been very weird, but I've been getting a lot of people now coming to me talking about herpes, right? So I don't know nationally. I haven't done any research about it. Is herpes on the rise? Are more and more people getting connected to it? Because I at least can say in the last 6 months, at least 4 people have approached me about it. And again, it's something that just necessarily doesn't have symptoms until it actually flares up. So it's one of those things where they're kind of embarrassed, when they do get a sore or blister, and to explain it and they find out about it. How do they navigate the conversation? And then, of course, we're focused on HIV and as we should be, and PrEP. So I think that so many people now are getting on PrEP and doing those things that they have become so relaxed now about other STDs and stuff that they're having. So we got to have complete conversations that I'm not just connecting you to someone who's going to help you around HIV and AIDS. I'm getting you to someone who's going to approach the conversation about STDs in general, right? And so stigma for that, stigma around sex workers, it's a lengthy conversation. It does annoy me sometimes, and I have to talk about my gay male counterparts to go to clubs and look at strippers and praise strippers all up and down and tip them a dollar, but you wanna demonize a trans person who may be doing sex work. Well, I'm sorry, strippers are sex workers too. It's all part of the industry. We've got to really start changing these conversations and narratives and stop demonizing people and really talk about how stigma is impacting us, how we are impacting each other, because that's not even a problem coming from the health department. It's how we judge each other, period. And so there is so much left to why this problem seems to fester within our own communities, what we're doing to each other. And thank you, Freddie, for bringing that up, because I think that stigma, especially around sex workers, is a big issue. And I think that trans women are tired to have to defend themselves. Someone had talked to me about there was a protest. I think Kim can probably name it better than I did, but it was something to the effect of walking while trans. And I know I went to a rally down in the village around it, and the trans women were really trying to say, just the assumptions that are being made or how they're being treated because they're speaking up around, the conversations around sex workers and HIV and other STDs. It's a problem. And the way we stigmatize them, it's a problem. So much we really got to change. It ain't going to happen overnight. But it's important that we have these kind of conversations and bring it to the light and say, this is stuff that's happening in our community. How are we dealing with it,
Absolutely. Thank you so much, Lee. Thank you to everyone who addressed the question. We're talking about what were barriers, right, to access care. And, so many things just came up. Education, the depth of education, where education takes place, not only in the context of a medical examination, but in our community, amongst each other, how we say, how we explain things to each other also impacts, right? How we have access. We mentioned again the intersections of poverty, social determinants, mental health, housing, and all these things we know are limitations. And again, of course, the lack of acknowledgement around sex work and the dignity that goes along with that is also missed. So I want to kind of move the conversation towards the end now, where we're talking about how do we fix this? How do we move beyond the barriers? And what, if anyone, just say, this is for everyone, one thing that you think is the most important thing to help people beyond the barriers of accessing testing and treatment when it comes to HIV and AIDS?
One of the things that I have done, I've been a part of 7 or 8 clinical trials specifically because Black people are woefully underrepresented. In fact, I had to fight. In fact, I had to fight to get into the Moderna trial because originally Moderna and Pfizer did not want HIV positive people in it. The HIV positive community rose up and got that. I go to clinical trials. Hey, I go to clinical trials just to say, and please don't think I'm a guinea pig. Believe me, it's signed consent. I sign form after form after form. Check, check, check. I know exactly what I'm doing. I'm not being gullible. I'm not being a guinea pig. I'm doing this because somebody went to a clinical trial for every HIV medication I'm taking in my body that's kept me alive. Let me say that again. Somebody's took those medications to see if they were going to work. That's kept me alive. So hey, let me do the same thing. That's how I lead by example. Okay, you're not going to invite me in. I'm there. Here I am. I'm not leaving till we do this. And I'm part of a network of studies. In fact, I got an invitation to be in a study now. But that's how I do it, by leading by example. Hey, you know, my people aren't in there, so at least you're going to have me in there.
Um, I'll say this is a broad one, but there's gonna take it's gonna take a I don't want to just say radical restructuring. I want to say first it needs to be infiltrated. That's the word I was looking for. An infiltration of the medical community writ large and all of its, surrounding factors. and a re-education. And I say infiltration not in a military sense, obviously. I mean that in a sense that the field of medicine and all of its pharmaceuticals and other factors that are implicated have been a money making machine first and foremost, and have also benefited from research that has been done on people of color and Black people particularly, but also indigenous populations, and also more people of color at large who are still coming to this country, right, are being harmed often, unfortunately, in different ways by individual actors. But I think that a lot of that comes from a legacy and a culture of the fact that medicine and all of its benefits were never intended to go to populations that are Black and populations that are trans and queer. And so we've had to do, as a whole society, as a whole world, a lot of catching up, right, and making amends to those wrongs. And the issue is, even though you're trying to make amends to those wrongs, I think sometimes we focus too much on, well, let's do it at the local level, or, communities will take care of all of it, or individuals. And we forget about the fact that the people who make this system kind of move, the doctors, the boards of these hospitals, the facilities themselves, the staff who are training people, the staff in charge of, taking care of, colleagues being trained on sensitivity, staff who take care of clients and client grievances. There's just so many different networks and departments and divisions and outside factors that go into the medical community at large that needs to be restructured, needs to be warped, and honestly so. So I think that we need to take an honest approach and an honest look at medicine, at doctors, at the relationship between doctors and patients. And again, not like every single element, but I'm saying particularly when it comes to the relationship between uh, the lack of access of the most vulnerable and marginalized communities, those being most often Black people, queer people, and trans people. Um, that is intentional, and there's a reason that it's there. And I think we need to take an even deeper look at why it's there and how it ever got here, because there is a paper trail. And once we do that and be real about that, I think that the second part is being real about the fact that that's going to take a radical restructuring. And that means that some people will be laid off because they no longer have the soft skills, such as cultural competency, for instance, to handle patients. And that's okay. People don't want to lose their jobs, but also you need to be incentivized sometimes. If maybe you've been there, Dr. Lee, Dr. Sally, Dr. Sue, for 50 some odd years doing your practice across multiple political regimes. And so all you've ever known is one way of doing it, and you don't think you're ever going to change. Well, then maybe your job should be up. Right. Maybe even if you are practicing medicine and you're the best at it, perhaps you're actually causing more harm than you think, than your renowned procedures are. One thing we didn't address is, going into the doctor's office and the actual aggressions of physicians and staff toward Black people, toward queer people, and towards trans people. I've had active aggressions between myself and physicians, passive aggressions mostly, none of them being like really real, being very passive about how they deal with their anger toward my Black body and my own seeking care. So I think that there's a lot to go with that, and the medical community has to account for itself.
I think that one more thing that I need to put on the table, it is the fact that, if in summarizing words, access and information. Lee asked me yesterday, we have a short discussion about having access to medications and to care. And I mentioned, and I've been troubled since yesterday about how can we make sure that everyone knows that information. That in New York State, if you need access to HIV, that you need access to PrEP medications, that if you're pregnant and you need access to prenatal care, you don't need to have a documentation of legal status. The fact that that exists, but it's not out there, It's going how many. God only knows how many people are not accessing medical care because they don't know that, and because we know that those medications are expensive. PrEP is an entry into primary care, and I think that we need to tell everyone that we know that that is available. The same thing with HIV. We know now that if a person becomes undetectable, also will become untransmittable. But then again, if I'm a newcomer to the States or afraid or was raised in a family with many hangups, I'm not going to talk to anyone. I'm not going to go to HIV clinic because it's not part of primary care. So I think that information and Lee, are we going to work in somehow in how can we put that information out so people will access care, will access testing, will access prevention, because we need to bring that out. And that's something that I think is by design, maybe, that we have kept that information from many that need and curious that, those resources that are available and out there for us to use.
Yes, I'd like to address that. So I think two things about the question that Solomon just said when it comes to barriers.
Oh, we
Most
got one thing, the most important thing. I want to challenge folks to think of like the most important thing. And it's going to be different for everybody.
Yeah. So as far as barriers go, I think there is two things to me. I think that well, I would like to see change. I would like to see that, and I know it can be done, but I know I posed this question 20 years ago about why haven't we normalized more testing? So if we can take away the stigma to it, if everyone, when you go into the emergency room or you go into a place, that HIV testing becomes part of the mandatory when they're checking your blood and they're checking all these other things, why can't we make that more mandatory and make it more across the board where it doesn't feel like you are being stigmatized or you feel uncomfortable about asking for interest in health, interest in care of those particular things. I I am so strong about it because around COVID, didn't that become mandatory? Almost every place you had to go, they wanted to know that you were tested for COVID. So we know we can do it. And I know that there's a cost and expense around it, which used to be the major argument of, do you know what that will cost hospitals to do and blah, 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 blah. Do you know what? You found the money to do that around COVID. You found ways to do that, to test it and get it out there when it came to monkeypox. Why was there such a holdback around HIV testing? So I'd like to say that that's a huge barrier that we need to knock that wall down and make, if you knock that down, then obviously the conversations of access to medications and all those things would change, and more people will be much more comfortable to walk into a hospital and have and navigate and have those conversations. The other barriers is there's so many, again, intersectionality of the way we all live is very different. And I tend to address things around Black Pride and conversations and the health conversations that I put together really based on the response coming from the community. If I see a lot of people are coming to me and talking about crystal meth and how that's impacting the community, then that year for the conversation, we're going to focus on crystal meth. This year, we talked about mental health, how we are all coming out of the pandemic and lockdown and how everybody was impacted with that. So I try to keep things kind of current to what I'm feeling from community when it comes to those conversations. But I guess I'm saying that to say is that right now, if we want to talk about what's current, we're seeing on the news that we have these migrants. So many migrants, and they're being shipped here now from other states, and buses are coming here. And how is that going to impact a system that already here in New York is already overloaded? And what does that look like now for those people that are, some people do know that New York has these laws around, getting on medications and help. But what people do struggle about with coming here is around housing. So it's great that you can go to the hospital and get some, but where are you going to live, which also impacts, their adherence to these things. So homelessness is an issue. So my last point to it that's really, I think, is is really important. I think sometimes with the New York City Health Department, the state health department, the CDC, is they need to start having more conversation when it comes to people of color with people that are gatekeepers. All of us here, we are gatekeepers to our community, whether we want to acknowledge that or not. We are the gatekeepers. We know how to navigate those conversations to people that look like us. I know how to, you come to me and you have a conversation, how I can respect your privacy, how I can, through the conversation, know how I can direct you to what resource and where you need to go. And if the health departments and these hospitals are having a problem trying to get people on these services, I always feel like I need to say, and I'm sorry, excuse my language, bullshit. Because there are ways for you to get the information out to the community if you really wanted it to. You could hold more community-based organizations as partners and bring us in to have the conversation and say, we need help. This is what's happening in this local hospital. It's impacting people that are coming to this hospital, are having these problems. How can you help me to get this information out without offending people, without stigmatizing people? We could do that. But it doesn't seem like we're at the front line. We're not at the table. We have to kind of fight our way in the door to saying, hey, I got people coming in having this conversation. How can you help me? How can I get them in here to get the services? So it shouldn't have to be that we got to push ourselves in the door. We should be invited in the door. If I'm making any sense to anyone, I'm saying that we are part of the solution, all of us, in some way, because we can help to give access to those people that they claim they can't reach, which again, I say is bullshit. You can't reach them because you don't want to reach them. We're there. If you can't find us, I'm tired of hearing the studies saying they can't get this population and that population because they don't know where to go. Bullshit. Who are you asking? Who are you talking to? They always want to say, well, Black people don't want to do this and they don't want to show up for this and they don't want to show up. No, you done made that excuse. You're using that as an excuse. Who have you talked to? You haven't invited the right people. You haven't gotten the information out to community enough to really make that judgment or make that judgment call. So I think those are the barriers. We have to really start to give more access to, you want to reach the trans community, talk to trans people in the community that are leaders. They can help you to get the information out to trans. You want to talk to gay males? Stop talking to straight heterosexual white males. They're not going to give you access to where Black gay males are at. They're not going to find that solution. Who are the people? Who are the community-based organizations? This is where we're going to make change. This is where we're going to start knocking down barriers. And we have to just start to kill the stigma. If everyone is tested on an equal basis, then there's no reason for shame to come into a space or feel like people are looking at you funny because you're asking about PrEP or an HIV test or where to go for help. So let's start eliminating that and making it part of the general conversation. I know 20 years ago, you could tell me it was the cost and who's going to pay for that. But child, y'all found money when it was COVID, right? We found the money. Everybody had to get a test. We had to walk around with a card. We can't go no place unless you can show the card that you got tested and you got a shot. So we can find a way to do that. And that happened relatively quickly. So if we could do that, we could do the same with HIV and AIDS. That's my point.
So for me, I think it's along the lines of continually having this conversation. And like Lee said, we need to have the conversation with gatekeepers. And that means all of us, the people in the community. We also need to do it with hospitals. We need to do it with us as medical, the doctors. It has to be everybody. It can't be just one particular source. Everybody, we all need to keep continually having this conversation because that's how it's going to keep going further and further. People are going to be educated. And now we're going to cause that to be a destigmatization of anybody coming in. We're going to test everybody. You're not going to look on people according to what Mimi said, like going to doctors and feeling a certain way. People, we need to be open and speaking to them. When you're in a hospital, it shouldn't be because something that's showing you is flu-like symptoms that you're testing. We should be testing it. These are ways we can help and have people understand more about HIV and AIDS and so forth, and getting people treated and living a healthy life. So that's my 2 cents on that.
Thank you, Nikita. Thank you, Lee. Thank you, Reginald. Thank you, Mimi. Thank you, Freddie. Thank you, Kim. Wow, what a conversation. And in this last portion, you heard about what some of those solutions are for the barriers that are forming for individuals from historical trauma to a lack of education. So the responses are leadership, taking up space inside of the medical profession in a way that would allow folks to be the decision makers and not the people who are excluded from the table. And also organizing community, getting our people together to understand better the power that we do have and the ability we have to make that change systemically. And one key thing both Lee and Nikita mentioned, standardizing HIV and AIDS testing, make it something that's normative, and that will help break the idea that it is abnormal. And so this is like very key information. And Nikita, also, thank you for adding the need conversation, continue dialogue. It's because when we start talking about things is when we start thinking that things are okay. And it's very, very easy to do that when we're trying to fight for system change. And that's why we are happy that we were able to have uh, our friend Kadeem hop on to pump up intro 895, which is now going to be moving through city council, which would help end testing deserts, which would give access for testing for HIV, AIDS, and also STIs in a rapid format. And not only that access, but also this bill includes the ability to be supported by a proper education plan. And we hope that when this bill that those gatekeepers would be the people who would be leading and disseminating that information to our community. And so we're grateful again to have you all with us to be able to share this information. People from all over different sectors of the community, and with so much knowledge to give. So I just want to thank you all from the bottom of my heart on this day, the National Black HIV and AIDS Awareness Day in Black History Month, to remember how a war against Black people has become medical. And it's not just about violence and incarceration, but it's about death through neglect in the medical field. And so I just wanted to end this a brief moment of silence for individuals who had been lost during this HIV and AIDS struggle. And we just commemorate those who have been HIV and AIDS affected with family members and those who have lost loved ones. So just take a little pause right now. Thank you. And I'll pass it off to Kim Watson Benjamin, our LGBTQ plus and health coordinator at the Office of the New York City Public Advocate, to give us a farewell.
I um I am really shocked. Transparently, I am really this has been powerful. This has been amazing. This has been a very imperative and needed discussion for all those individuals out there. Continue this conversation like each and every one of the panelists said. Each and one of these panels are we are all human beings. We're providers, we're service providers, we're gatekeepers, we're all of that. Like Lee said, that you could come to any of us and bring us to your tables. Because we know how to build our own tables to bring you. And we all have information that we can end the epidemic, end the pandemic. We can do all those things, but keep us in the conversations, because the same way that you can find vaccines for monkeypox or for COVID, we're still waiting on a vaccine for HIV and AIDS. So let's be really transparent with all of that. Let's where all that money is going. Can we put it back into where the epidemic of HIV and AIDS? I want to say Start Loving Us campaign is out. Me as the LGBT and health coordinator, we have a campaign that for Black and Brown individuals. I will continue sending you emails. It's up to you to show up and show out every second Thursday of the month at 11 o'clock for 2 hours. Just 2 hours to chat and talk about all these discrepancies, all these barriers, and all the enhancements that we could put on the whole epidemic and the pandemic. Listen to me, y'all. It is here. Utilize the tools, enhance the tools. It is here. Come on. Come on with me. Y'all know how we do. Come on. Come on with me. Think of me a Rosa Parks. Think of me a Graham Bell. Think of me a Frederick Douglass. Think of me of Martin Luther King. That's when I was born, the 15th of January. Come with me. Because y'all know that y'all have been coming with me and I have never stirred you around. So I want y'all to come with me. So being the LGBT coordinator and the health coordinator and a public advocate for the last 2 years, I have invited you to the table. And it's not even voting season. Just come with me. Trust and believe. Each and every one of you have a story to tell about me. And you know, I don't play. I am just transparent. I am humble. I'm organic. And I'm the intellectual, educational individual that you understand that I will never take any resources with me. I want to share it. I want you to start loving us. I want you to put this campaign. If you find some money out there, know anybody that got money, let's get some paraphernalia. But start loving this campaign. But y'all heard it here first. Y'all could do t-shirts, y'all could do buttons or anything. You heard it here at the OPS office. I want you to never forget that because I create history. I build tables and I leave tables because I think about passing the baton on. It is not about me. It's about community. It's saving those lives. Because if I can't save those lives or save my own, what purpose am I here on this earth for? Remember, I want you to come with me. Start loving this campaign at the Public Advocate's Office, Jemani D. Williams. You would not even regret it. Click on that link.
Thank you so much, Kim. Have a beautiful night, everyone. Thank you, New York City.